In studio with the Admiral Bill Stubblefield. William.
Good morning again, Rob. Great to be here.
New York Times bestselling author John Gilstrap.
A pleasure to be here.
You have
an honor.
Author company today.
Indeed.
By the way, Ronald Gruner had a 40-year career as the founder and CEO of 3 technology companies. Drawing from his business experience, he published We, the Presidents in 2022, A Presidential History, which explores how the policies of American presidents have affected America and the world today. He's taken a similar approach in COVID Wars. In his latest book, he discusses how deep divisions within America during the COVID pandemic affected our death rates, personal freedoms, and national economy. He joins us via telephone. Ronald Gruner, good morning. You're on Eastern Panhandle Talk with Rob, John, and Bill. Great to have you.
Well, good morning, gentlemen. Thanks for the invitation.
I have read almost all of the book that I got in advance of this interview, and I have to tell you, this is a very data-centric book that references a lot of evidence as to death rates and how each state handled the pandemic and such. When you approached this book, did you approach it with the idea that here's what I want the ending to be, and I'm going to select the data I want to support it? Or did you come in with, let's find out what happened, let's analyze data, and then figure out what happened?
Well, the latter, Robert. I mean, I'm an engineer by trade, and so I tried to approach the book at the very beginning 2.5 years ago, really trying to understand what happened. I didn't, like most Americans at the time, really didn't have a firm idea of what was causing the problem and why we were so confused as a nation. So I try to start from the beginning, and as we engineers say, data drives out speculation. So I try to look for data that was trustworthy data and build my book on top of that.
You also referenced previous pandemics. You went back to 1665 with the bubonic plague, 1918 with the Spanish flu, and then other outbreaks which happened along the way which weren't as dangerous or as deadly as some of those other pandemics were. And what did you find by comparing history in regards to pandemics of the past to this one most recently?
Well, there are many, many similarities. Going back to the Great Plague of London in 1665, Daniel Defoe, who wrote Robinson Crusoe, wrote a recounting of that 65 years later using the diary of his uncle. And for example, in London, the wealthy people, the privileged people, they left London in droves, leaving people that were unable to do that to suffer through the plague. And most of the deaths were people in London that were left to live in London because they couldn't leave the city. There were, of course, all kinds of theories as to what worked and what didn't. There were lots of quacks, for example, in 1665 selling solutions that would cure the epidemic, but of course those did not work. And we saw similar things, of course, during the COVID pandemic in just the last few years. Many similarities. And another similarity was in 1918, the country very quickly divided between cities, states, and even cities that chose to basically practice social distancing and be focused on public health, whereas opposed to other cities were more focused on maintaining their personal freedoms. And so you saw divisions happening in 1918, just like we did here in the States during COVID.
How did the United States compare in regards to developed nations and how we handled COVID versus the death rates in other countries around the world?
Well, that's one of the conclusions of the book, and the data is pretty much undeniable. If you take the 20 largest developed nations, excluding China, whose data is not reliable, in my opinion, of those 20 developed nations, the United States, during the pandemic, 3 years, had the highest COVID death rates, about 3,200 deaths per million, which was the highest of all the nations. That's including Germany, which has a population 10 years older on average than the United States, for example. Canada was 1,200 versus our 3,200. So we were, unfortunately, at the very high end of that scale.
And in regards to the data you collected, what did you find as to the reasons why the United States had such a higher death rate?
Well, it's an interesting but complicated question. We have, in America, although we have the highest cost per capita for health care, about $12,000 per capita, double other developed countries, we have an average lifespan in the United States before COVID about 4 years shorter than other developed countries. We have a much higher obesity level, which contributes to higher death rates. We have a much higher maternal death rate by a factor of 2 to 3. So going into the pandemic, we were a much less healthy nation. That's the first factor. The second factor is that I think we were, as a nation, much more divided than many countries were. Take Canada and Germany, which were quite united in how they're going to approach COVID. We kind of divided ourselves along two lines. One line basically focused on maintaining social distancing and wearing masks as much as we all hate that, and vaccines. And other parts of the country, we tended to resist vaccines and social distancing and masks and things of that nature. So we saw a change. If you look at the county level, between the counties that had the lowest death rates and the counties that had the highest death rates, a factor of 5 or 6 to 1. That's a huge difference. And even in states, which of course have a mix of counties in them, we saw changes of as much as 3 to 1 between the lowest death rates and the highest death rates. So we were a very divided nation during COVID.
Bill?
Yeah, Ron, I found your questions that you provided us and the answers to be very enlightening. I think we could spend a full hour just going through these questions one by one. You made a point, though, that I found to be interesting, and we think of COVID as being strictly health-driven, but it was also an economic input, that the typical American found their income declined by several percentage points during the COVID years, something that I think we were vaguely aware of, but you make the point much clearer. Discuss the economic issue for a second, if you will.
Well, the first impact was in March and April of 2020, as the pandemic was hitting. 21 million people lost their jobs. Businesses, small restaurants, businesses, hotels, restaurants, all cut back and laid people off. So over 20 million people lost their jobs within the first 3 months of the pandemic. That had a huge economic impact on us, and of course generated a lot of social dissension. So that was one factor. But I think what you might be alluding to, Robert, is that if you look at the end of the pandemic, the official pandemic, 3 years later in 2023, if you break the United States population into 4 groups by income, from the lowest 25% to the highest 25%, all of those groups basically had no increase in income or declined slightly. But if you take the top 0.5% of the United States, which is people making $2 million more a year, their personal worth and income more than doubled during the pandemic. So the very wealthy did very well during the pandemic in terms of their economic income. If you can just look at the stock market boomed during the pandemic. It went up by a factor of 40%, yet employment was flat to down. So people that were working for jobs on an hourly wage, they saw no real improvement. But people that had capital in the stock market, they did extremely well. So there's a large disparity in income during the pandemic.
John Gilstrap.
Good morning, Ronald. This is a topic that's a very raw wound for me, and not because of any personal experience or great loss from the disease, but because of manipulation, what I interpret as manipulation of data and the truth, not by you, but by politicians. And a very dear friend of mine, not with us anymore, he, right before COVID, he had a bilateral lung transplant. And then COVID hit his transplant. He had some rejection issues. And then in the treatment of the rejection issues, he then had renal failure. And then he had some really severe problems with dialysis. And he lived in New York City. In the height of COVID, he was admitted into the hospital. In the hospital, he developed COVID and he died. His cause of death was COVID. As opposed to all of those other terminal issues that he had. I've heard apocryphal stories from where people who were shot or hit in automobile accidents and admitted to the hospital had COVID. Their cause of death was COVID, as opposed to the bullet wounds. I don't know if those are true or not. In your research, the rumors that I have heard, were hospitals compensated for COVID deaths by the government in a different way through some, I don't know, Medicare or whatever the program would be? Were there payments made to hospitals for a diagnosis of a COVID death?
The answer to that is yes. They weren't compensated on deaths, so if somebody died, they didn't get extra compensation. But patients that were in COVID ICU units required significantly more medication, intubation, they much more treatment, 24 hours, all kinds of issues. So they were compensated for that. So there arguably was a financial motivation to diagnose somebody as having COVID. Now, I want to make a couple of points on that because that's a very interesting and important issue. It was oftentimes, in the case of your friend, that tragic situation, it was a case of a coroner saying, did that person die with COVID or because of COVID? And that was a call, that was made 1 million times in the United States. The key thing to look at, I think, John, is you have to look at the death rates in the United States from 2009 to 2019. That was on a very, very steady, small increase per year of about 1.5% year in and year out as our population aged. Then the total deaths jumped up 3.5 to 5%, as I recall, in 2020. So the number of deaths increased tremendously. And right now, the analysis is that 80 to 90% of those deaths in 2020 and 21 were COVID-based, and the others, like perhaps dying of cardiac deaths, were because hospitals were at capacity or COVID made those situations far worse or other factors. But there was a huge increase in deaths, both COVID and other deaths, in 20 and 21 compared to the historical rate.
Is there a way, you're a numbers guy, statistics guy, and now you get a lot of moving targets, right? So is there a way to determine how many ancillary deaths there were caused by all of from the undiagnosed cancers from the time that the hospitals were closed and all they were doing was COVID and that sort of thing?
Well, yes. I mean, I have a full chapter in the book on that. One chapter is called COVID deaths, specifically focused on COVID. The other chapter is excess deaths. That's deaths beyond COVID, which represent maybe 20% of the deaths beyond the normal level. And I analyze that on a year-by-year basis, and that data is definitely available. I'll make one other quick point, if I can. Obviously, there's a lot of distrust about the data and distrust for the CDC, the Centers for Disease Control and Prevention. What I point out in my book is that data comes from the state, and the state gets it from your local county health bureau. And one of the things I did as part of my due diligence is I would take the analysis at the county level, published by the CDC, and then go back to the counties, including my county here in Florida, and confirm that the county data that they publish is identical or very, very close to identical to what the CDC published. So that CDC data is based on the data in your hometown, and I verified that personally, and I suggest to readers in my introduction, if you're skeptical of the data, do that. Go to your health bureau in town and check out the data.
Ron, picking up on this, there's a tremendous amount of data. I would make the analogy of drinking out of a fire hydrant. There's so much data coming out. One would think that the data would take years to synthesize and to get a understanding of the validity and the credibility of the data. Yet you've been able to do this in 2 or 3 years. How were you able to do this? How were you able to analyze the data and develop some criteria for the credibility?
Well, I think many people could do that. I happen to focus on that. But like I said, my background is an engineer. You pointed out that I had started 3 companies. 2 of those companies were data companies. My company was the first company to put shareholder information, investor relations information on the Internet. And we had 1,000 public companies. We were providing financial information to the public on the Internet. So my background goes back to basically data analysis, and I've done that almost my entire life. So that kind of comes naturally to me. And many people could do that. A good engineer focuses on data. They say, let's start with the data, confirm the data's right, and then do the best we can to analyze it. But I'm the first to recognize that, there's the old joke, allegedly Mark Twain, there's lies, damn lies, and statistics. So I'm aware that statistics can be twisted, but we tried our best not to do that.
Ronald Gruner, our guest here, author of the book COVID Wars. This is a data-centric analysis of the COVID period and related deaths and such. So ultimately, the country dug in on a couple different camps. 1, the vaccine works. 2, the vaccine doesn't work. And in the aftermath of that, the vaccine causes heart problems and sudden deaths in young people as well as others who took the vaccine. What does your data tell us about how effective the vaccine was at helping people not die of COVID? And what does it tell you about the claims that many people died because they took the vaccine?
Well, people did die because they took the vaccine. The vaccine did cause myocarditis deaths in young people, 24 years and younger. But my analysis, which I discuss in the book, as best I can estimate, was it affected dozens of people during the pandemic who died of myocarditis and vaccines, not thousands or hundreds of thousands. Whereas COVID itself, particularly long COVID, if you know people that have long COVID, very, very often have very serious heart issues. And so there's something with the virus, the COVID virus, that affects the heart. And, of course, that is manifest in the vaccine to a smaller degree. But people did die of myocarditis because of the vaccine. But it was in the United States, as best I can analyze, in the dozens, less than 100 per year, as opposed to thousands and thousands that were dying of COVID.
What did your research tell you about, I know you touched on this earlier, open states versus closed states, and how did you define each to determine which qualified?
There were two groups that defined that. Well, one that measured how open the schools were, and one that measured how open the communities were, and they ranked the states from most open to least open, most open schools to least open. In terms of schools, the states and the counties that were the most open had the smallest decrease in scores and school dropouts of the state. So it tended to schools that stayed open did better than schools that closed. But the difference, this is a point that's interesting, the differences are small. Even in states like Wyoming and South Dakota that remain completely open, they saw increases in dropout rates of 1% to 2%. Whereas the states like Connecticut, which closed their schools and kept things shut for a long time, saw dropout rates of maybe 2.5% to 3%. So the differences were relatively small. Most of the impact was due to COVID itself, not the school closings. But on the economic side, once again, the states that remained open had a smaller economic impact, smaller loss of employment than those that closed. There's no question about that.
In regards of COVID's effects on those states, number of people who got sick and died, what was the difference?
Significantly higher. So the states that remained open and very typically tended to be vaccine hesitant, those two went together, almost always had higher death rates by a factor of 25 to 100%. And I analyze that a lot. I give a number of examples of counties. It goes from the county level, the city level, to the state level. A very clear trend.
What about Republicans versus Democrats or independents?
And that was something I found very disappointing. I analyzed what were the factors that, to use the term, correlate with the COVID deaths. I mean, income, education level, smoking, obesity, all those things tend to increase or, affect COVID death rates. But if you look at the single factor is the best predictor of who dies and who lives in a county or a state, it was political orientation.
Who died more?
Republicans, unfortunately.
Was it significant or just a negligent difference?
No, the book you'll point out, you'll see differences in Republican counties or cities, and I'll give you an example in just a second, was oftentimes a factor of two. I give the book a lot of examples, very concrete examples, very easily identifiable. I take two counties in Texas. Texas is a very red state, and Midland County, Texas, is a county of about 180,000 people. And I don't recall the exact numbers, but they had a death rate in Midland County, Texas during the pandemic. I mean, I'm talking now in 2021 and 22, after states had opened up in general and vaccines were available. That was roughly 3 times higher than the same size county in Vermont, which tended to focus on vaccines and distancing, et cetera. But just 200 miles away is Travis County, which is a home to Austin, Texas, the capital of Texas, which was a highly Democratic county, which had much, much higher vaccine rates and a death rate half of Midland County, just 200 miles away. And the big difference is political orientation, and that affected how people looked at vaccines and other factors.
Bill?
Ron, what
John.
do we learn? What do we learn from that perhaps was captured in your book?
Well, the advice I'd give to people is, if you don't trust the government, I understand that. But we've got some of the best medical institutions in the world. You have the Mayo Clinic in Minnesota. You've got the Mass General in Boston. You've got great, great hospitals all through Texas, Stanford in California. And go check those people out. See what they're saying. And if they're saying vaccines work or masks work, I would believe that because we have some of the best institutions in the world. And if we get really sick, that's where we go. We don't go to somebody on the internet broadcasting on a podcast. We go see the best doctors we can. We've got those. We should trust the doctors.
But minding down a little bit, if we had another COVID pandemic like we had, were the lessons learned such as shutting down our economy, shutting down the schools, that would give us guidance on what we should do for the next pandemic?
Well, it's going to take a while to absorb those lessons, and I think we're really not quite sure how it all affected. I mean, even shutting down schools had a kind of a counterintuitive effect. Suicides dropped tremendously in the states that shut down their schools. And people would say, well, how did that happen? Because you had all this emotional impact on students. Well, suicides really with school students are caused by bullying. So if you're in school and you're bullied, those are the kids, unfortunately, that commit suicide. So if they're not going to school, suicides decrease tremendously. It's saving about 1,000 deaths a year, as I recall.
What was the... Go ahead.
Yeah, we only have 30 seconds left. It'd have to be a really quick question and answer.
What was the overall fatality rate for healthy adults from COVID?
For healthy, about 2,000 deaths per million on average.
Ronald Gruner, thank you so much for your time here this morning. Always appreciate anybody who's got data on this pandemic here, and not enough of it around, I don't think. It's called COVID Wars. Ronald, thank you very much. Best of luck with you to you on the book.
Okay, thank you, sir.
Thanks,
Bye-bye.
We are back with a final minute after these.